Welcome back to Neurology 101 here on the ProPA podcast. I'm Dr. G, and today we are taking a little bit of a backpedal into our other encephalopathies subseries with a must-know, testable, and clinically relevant condition, Wernicke's encephalopathy. This one is high yield for the PANCE, especially in alcohol-related questions and post-op complications. You've got to catch it early to save a life and brain function. Let's dive in. Did you know giving IV glucose before thiamine can actually precipitate or worsen Wernicke's encephalopathy? Why? Thiamine is required to metabolize glucose. No thiamine, no energy. Neurons suffer. That's why the classic teaching is thiamine before glucose in at-risk patients like alcoholics or those with malnutrition. Let's look a little deeper at the kinder patho. What is Wernicke encephalopathy? Wernicke encephalopathy is a neuropsychiatric syndrome caused by thiamine or vitamin B1 deficiency, leading to impaired glucose metabolism on the brain. The most vulnerable regions include the mammillary bodies, the thalamus, and periventricular regions of the brainstem. Without thiamine, neuronal energy production plummets, leading to cellular injury, edema, and dysfunction. Some of the most common causes include chronic alcohol use. I like to remember it this way. Alcoholics get Wernicke encephalopathy, don't B1. B1 standing for thiamine. Malnutrition can also cause it, post-bariatric surgery, cancer, or hyperemesis gravidarum. Certain eating disorders can be vulnerable, and prolonged IV glucose without vitamin supplementation. How do these patients typically present? Well, we tend to have a classic triad, but it's rare to see it in real life. We have encephalopathy, which includes confusion and apathy. We have oculomotor dysfunction, including nystagmus, lateral rectus palsy, and gaze palsy, and gait ataxia. A mnemonic you can think of is CAN, confusion, ataxia, nystagmus. Other symptoms include memory issues, hypotension, hypothermia, and confabulation, seen more often in Korsakoff syndrome, the chronic version. This is a clinical diagnosis. Do not wait for imaging. So, again, how do we diagnose? This is a clinical diagnosis. So, labs and imaging help, but treatment shouldn't be delayed. Labs can include a low serum thiamine, but not always readily available or reliable, and other vitamin deficiencies. Imaging, an MRI is more sensitive than a CT, and classic findings include symmetric hyperdensities in the mammillary bodies, thalami, and periaqueductal gray. But again, don't wait for imaging if you're suspicious. How do we treat it? Well, high dose IV thiamine immediately before glucose. Usually we give 500 milligrams IV TID for 2 to 3 days, then taper, and we want to follow with oral thiamine once stabilized. Always replete magnesium as well. It's a cofactor for thiamine activation. Other supportive care measures include nutritional support, electrolyte correction, alcohol cessation if applicable, and early treatment can equal full recovery. Delayed treatment has a risk of irreversible Korsakoff syndrome, which is a chronic amnesic state. Now let's look at the book med versus the street med. So book med, we're going to have a thiamine deficiency which causes Wernicke's. Give thiamine before glucose. Street med, that confused, disoriented patient with a history of drinking might not just be drunk. They may be dying of a treatable brain injury. Time is neurons. Give thiamine early. Now for some quick clinical pearls. Always suspect Wernicke's in an alcoholic or malnourished patient with altered mental status. Don't wait for imaging. Treat first, ask questions later. CAN triad is a classic, but not always complete. IV thiamine is cheap, safe, and potentially life-saving. And magnesium matters. Replete both. All right, it's time to test our knowledge. So, we have a 54-year-old male with a history of chronic alcohol use who is brought in confused, with an unsteady gait and a horizontal nystagmus. You suspect Wernicke encephalopathy. What is the next best step? Is it A, a head CT, B, serum thiamine level, C, IV glucose, or D, IV thiamine? I'll give you a few seconds. If you said D, IV thiamine, you are correct. Wernicke is a clinical diagnosis. Delay in thiamine treatment can cause irreversible damage. Give IV thiamine ASAP. What is the most common structure affected in Wernicke encephalopathy? Is it A, the amygdala, B, hippocampus, C, mammillary bodies, or D, caudate nucleus? If you said C, mammillary bodies, you are correct. These are classically involved in Wernicke's and show symmetric enhancement on MRI. So, some final thoughts. This isn't rare, it's underdiagnosed. Wernicke encephalopathy is a time sensitive emergency, masquerading as confusion or intoxication. If you remember nothing else, thiamine before glucose always. Coming up in our next neuromuscular disorder series, we have essential tremor, a classic PANCE favorite. If this episode helped you lock in one of those can't miss neurodiagnoses, share it with your cohort or clinical team. And as always, this is the Pro PA podcast, where future pros in medicine are made. Until the next episode.